This slide summarizes the lumbar spinal nerve roots from L1 to L5, highlighting their motor innervation, principal muscle supplied, major actions, dermatomes, and important clinical correlations. On the left, notice the lumbar nerve roots emerging from the spinal cord. The lumbar enlargement gives rise to the L1 through L5 nerve roots, which descend within the vertebral canal before forming the cauda equina. L1 nerve root. The L1 nerve root supplies the iliohypogastric, ilioinguinal, and genitofemoral nerves, with additional contribution to the psoas major and quadratus lumborum muscles. So the L1 root supplies which nerves? Iliohypogastric, ilioinguinal, and genitofemoral nerves, with additional contribution to the muscles. So these muscles are psoas major and quadratus lumborum muscles. So what are the primary actions? The primary actions of this L1 nerve root include contraction of the lower abdominal wall, weak hip flexion, and lateral flexion of the spine. So what are the primary actions? Contraction of the lower abdominal wall, weak hip flexion, and lateral flexion of the spine. The L1 dermatome covers the groin and upper medial thigh. What is the sensory supply? The L1 dermatome, groin and upper medial thigh. So clinically an L1 lesion, what does it cause? Weak hip flexion, sensory loss over the groin and upper medial thigh, and a reduced cremastic reflex. So together with L2. Then coming to L2 nerve root. The L2 nerve root, mainly through the femoral nerve, supplies the iliopsoas, pectineus, and sartorius muscles. So what does L2 nerve root supply? Iliopsoas, pectineus, and sartorius muscles. So what are its major functions? Its major functions are hip flexion, hip adduction, and assistance in knee flexion. Hip flexion, hip adduction, and assistance in knee flexion. The L2 dermatome lies over the anterior and medial thigh. L2 dermatome, where does it lie? Over the anterior and medial thigh. And L2 radiculopathy presents with weak hip flexion, reduced knee extension, and sensory loss over the anterior and medial thigh. So here L2 radiculopathy, weak hip flexion, reduced knee extension, and sensory loss over the anterior and medial thigh. Coming to L3 root. L3 root, it supplies the quadriceps femoris muscle group. So which is a nerve root supplying the quadriceps femoris muscle group? Nothing but L3. So rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius. Rectus femoris, vastus medialis, lateralis, and vastus intermedius. So what is its principal action? Quadriceps means knee extension with assistance in hip flexion and stabilization of the patella. L3 means, remember, quadriceps, which is responsible for knee extension, and this also assists in hip flexion and stabilization of the patella. The dermatome extends across the anterior thigh and knee. So what is the dermatome? Anterior part of the thigh and knee. So clinically L3 involvement results in weak knee extension, diminished or absent patellar reflex, and sensory loss over the anterior thigh and knee. So remember, L3 quadriceps, knee extension, anterior thigh, and sensory loss over the anterior thigh and knee, and absent patellar reflex. Coming to L4 nerve root. So this L4 nerve root contributes to the quadriceps. L4 nerve root contributes to quadriceps, adductor longus, adductor brevis, and tensor fascia lata. Okay, L4 quadriceps, adductor longus, adductor brevis, and tensor fascia lata. So this action also include knee extension, hip adduction, knee extension, and this hasn't something extra. This is hip adduction, pelvic stabilization, and medial rotation of the thigh. So the L4 dermatome extends along the medial leg to the medial malleolus. So an L4 lesion produces weak knee extension, weak hip adduction. So L3 only knee extension. Here knee extension along with hip adduction and sensory loss along the medial leg and medial ankle, whereas L3 sensory loss over the anterior thigh and knee. L5 nerve root. So L5 means supplies the tibialis anterior, extensor hallucis longus, extensor digitorum longus, gluteus medius, gluteus minimus and part of the tensor fascia lata. So L5 tibialis anterior, extensor hallucis longus, extensor digitorum longus, gluteus medius minimus and part of tensor fascia lata. So what are its major functions? Ankle dorsiflexion. So here it comes to ankle dorsiflexion, great toe extension, foot eversion, hip abduction and pelvic stabilization during walking. So what are its major functions? Ankle dorsiflexion, great toe extension, foot eversion, hip abduction and pelvic stabilization during walking. So the L5 dermatome involves the lateral leg and dorsum of the foot. L5 lateral leg and dorsum of the foot. So L5 radiculopathy commonly causes foot drop, L5 radiculopathy, weak great toe extension, weak hip abduction and sensory loss over the lateral leg and dorsum of the foot. So what are the main muscles supplied? So L1 supplies psoas major, hip flexion and trunk flexion when the femur is fixed. L2 iliopsoas, which is the strongest hip flexor. L3 quadriceps femoris, the primary extensor of the knee. L4 hip adductors, adduction and stabilization of the thigh. L5 tibialis anterior, ankle dorsiflexion and inversion. And L5 gluteus medius, hip abduction and pelvic stability during single leg stance. L1 psoas major, hip flexion and trunk flexion when the femur is fixed. L2 iliopsoas, strongest hip flexor. Quadriceps, extensor of the knee. L4 hip adductors, adduction and stabilization of the thigh. L5 tibialis anterior, ankle dorsiflexion and inversion. And L5 gluteus medius, hip abduction and pelvic stability during single leg stance. Okay, so the lumbar plexus is formed by the anterior rami of L1 to L4 within the psoas major muscles. Lumbar plexus formed by the anterior rami of L1 to L4 within the psoas major muscle. So major branches include the ilio-hypogastric, ilio-inguinal, genitofemoral, lateral femoral, cutaneous femoral and obturator nerve. The L4 and L5 roots continue as the lumbosacral trunk contributing to the sacral plexus. L4 and L5 roots, they continue as the lumbosacral trunk, so contributing to the sacral plexus. So what are the clinical pearls? Clinical pearls are L2 to L4 weakness cause difficulty climbing stairs and raising from a chair. L2 L4 cause difficulty climbing the stairs and raising from a chair. The patellar reflex primarily assess the L3 and L4 nerve roots, patellar reflex. An L5 root lesion typically produces foot drop and difficulty walking on the heels. L5 root lesion, what you have to primarily test? You have to test for any foot drop and difficulty walking on the heels. Dermatomal sensory loss helps localize lumbar radiculopathy. So L1 to L4 form the lumbar plexus within the psoas major muscle. L4 and L5 contribute to the, so these are the key messages, contribute to the lumbosacral trunk. Lumbar roots primarily control hip, thigh, knee and ankle movements. Lumbar roots control hip, thigh, knee and ankle movements. Muscle weakness, dermatomal sensory loss and reflex changes are essential for localizing lumbar nerve root lesions. So if it is ankle dorsiflexion and inversion, it is by tibialis anterior L5 root, and hip abduction is also by gluteus medius. Okay, and hip adductors means L4, quadriceps femoris means L3, L2 iliopsoas, which is the strongest hip flexor, and L1 is the psoas major causing hip flexion and trunk flexion when the femur is fixed.